What are the neuroanatomic components involved with dementia? Stay tuned because today you will discover how neuroplasticity is related to dementia and how we can help patients suffering from cognitive decline. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute and your host on the Virtual Neurology Summit. The purpose of the Virtual Neurology Summit is to provide healthcare professionals with brain-based solutions to get better neuroplastic results with your patients. I'm honored to welcome our next guest expert. Dr. Randy Beck is an internationally renowned expert in the field of clinical neuroplasticity and neuroplastic restructuring techniques. He graduated from the University of Western Ontario, London, Canada, with an honors degree in physiology and pharmacology, and North Central University in Arizona with a PhD in psychoneuroimmunology. He subsequently completed postgraduate studies in non-invasive brain stimulation at Harvard University. Dr. Beck has authored 3 textbooks in functional neurology that have formed the academic foundation for the field and authored or co-authored over 30 published peer-reviewed manuscripts in academic journals. Today, he'll be sharing with us dementia and the neuroplastic brain. Dr. Beck, thank you so much for joining us as a speaker on the Virtual Neurology Summit. Please take it away.
Welcome everybody to this presentation for the Virtual Neurology Summit. And I'm really glad you could join us for this. I think we're going to cover some very exciting stuff today in this presentation, dementia and the neuroplastic brain. So first of all, we're going to talk about normal brain aging. And normally when our brains age, we look for, subtle cognitive changes that may happen, that happen to most of us. In fact, things like declining in attentional ability, the ability to attend to things, some decline in episodic memory, some decline in working memory function, maybe some decline in processing, psychomotor speed, that type of thing. And basically, these have all been considered as inevitable changes when we age. Now, there are a lot of changes that happen when we age, particularly ventricular enlargement. So enlargement of the areas of the brain known as the ventricles, which are containing cerebrospinal fluid. We start to get some cortical thinning, so thinning of the actual cortex of the brain. And remember, the cortex is the part of the brain that has the neurons in it. And then the axons from those neurons go out from the cortex to other areas of the brain, other areas of the nervous system. Okay, now we also start to get actual volume loss of the body of the brain, in the morphological regions of the brain. We also get some sulcal widening. So the sulcus that are in between the folding areas of the brain start to, because the tissue that forms the sulcus is starting to get smaller, the sulcal area itself starts to expand. Now, because the aging processes that we have just discussed, the inevitability of those has actually been brought into question as to whether the beginnings of these aging processes could actually be the start of what's called a prodromal stage of dementia. And it may be difficult to distinguish between a prodromal stage of dementia and regular normal brain aging. So basically, it has led some researchers to consider that normal cognitive aging and dementia be part of a continuum. So we start with loss of stuff from normal aging along this continuum, and then eventually develop into some kind of dementia, the most common type of dementia, which is Alzheimer's. Okay, so basically dementia is a syndrome of gradual progressive cognitive decline due to a variety of underlying pathologies. And we don't understand what all those pathologies are at the moment, but they're complicated and there are many. Let's just understand that. So Alzheimer's disease is one of the most common causes of dementia, although in fact, it's now recognized that up to half of all cases of Alzheimer's disease demonstrate pathologies on autopsy that include things like inflammatory or vascular components. So it's a complicated process that we're trying to investigate here. But remember, what we're trying to point out here is that the cognitive decline of aging is on we want to consider it on a type of a continuum. Okay. And that's sort of the important aspect I want to get through right now. It's on a continuum. And this continuum, there's thought to be a prodromal stage of dementia in which the level of cognitive impairment is evident beyond what we would be considered normal cognitive aging, but does not meet the diagnostic criteria for any kind of dementias, including Alzheimer's disease. Now, this has been given the title of mild cognitive impairment. So if we look here on the graph, so we get the graph here shows along one side cognitive decline, along the other side is time. So we start to see over time, everybody sort of has a bit of cognitive decline, which we've talked about, resulting in all those types of physiological changes that we just discussed. However, in some people, this decline will then deviate a bit more radically. And in this period where it hasn't yet affected the activities of daily life of the person, but we do see cognitive changes and we do see a little bit more memory impairment, a little bit more, impairment of cognition, a little bit more impairment of memory, but not to the extent that it's involving their life. We call that mild cognitive impairment. Now, this is a very difficult stage to develop, to diagnose whether Alzheimer's disease is happening or not, or whether another form of dementia is happening or not. And then suddenly it takes if this mild cognitive impairment continues, then it suddenly takes a rapid decline. And we don't want anyone to get into this red area because that is dementia proper, where we have a cognitive impairment severe enough to interfere with the everyday activities of life. So really, we want to keep people up here, obviously, into the green and even into the blue area here, but not down into this black and red line. Okay, so let's talk about mild cognitive impairment again, because this mild cognitive impairment is further divided into clinical subtypes based on the characterization of cognitive impairment that is involved in the process. So we have one big category which involves memory, another big category that involves thinking skills, another category that involves language difficulties, obviously another category, disorientation in time and space, and then another category which involves poor judgment. So basically, if we go back, so in normal aging, we may experience all of these things. However, it's a bit more mild in its expression. So for instance, in normal aging, you might miss one monthly payment in a memory issue. But when we get into mild cognitive impairment, it starts to become challenging to take care of all your monthly bills, for instance. Impaired thinking skills, you lose some things from time to time. Now in a mild cognitive impairment, you're misplacing things often and you're not even able to find them. Language difficulties, sometimes you forget which word to use, and this is in normal aging. Now, in mild cognitive impairment, you might have some troubles actually having a conversation. So you can see from normal aging to mild cognitive impairment, there is this definite change in the way it affects your life. Okay, so disorientation in time and space, you forget what day it is, but you remember later. So, occasionally you'll have that in normal aging. Now, in mild cognitive impairment, you lose track of the date and time of the year, and it does not come back. You don't actually remember in a short span of time where you're at. So these are all examples of how these two may be differentiated. So poor judgment, you make a poor decision every once in a while, or you make poor decisions a lot of the time. So frequently you're making poor decisions. That falls into the mild cognitive impairment category. Okay, now let's talk about the concept of cognitive reserve. So cognitive reserve basically involves when we have people, we often have people that in their clinical presentation will present with the progression of dementia symptoms that vary among people. And in some people, the symptoms that they're experiencing do not match what we would expect the symptoms to be based on the amount of damage that has been done. So we had to come up with something to explain this. So one of the concepts to explain this is basically the concept of cognitive reserve, which basically is the hypothetical ability of the brain to vary in different individual capacities based on how the brain has built up capacity prior to the injuries starting to happen. Okay, so we can look at what are some of the things that can build up this cognitive reserve. So things like external environment. So we have basic categories like external environment, we have lifestyle and behavioral choices, personality and individual thoughts, and then of course we have genes. So your genetic makeup can also influence what your cognitive reserve could be. So the basic concept of cognitive reserve is that you have enough active, good brain tissue to be able to withstand some of the damage that's going to be done during the demential process or during the aging process. So that someone with a larger cognitive reserve could go longer than someone with a less cognitive reserve at the same amount of damage being caused by the dementia process. And these are the main things that will influence that. So external environment, so things like if you've had infections, do you have a good healthcare system that is taking care of you, basically throughout your life? Air pollution, the economics in which you have grown up. And then we go to lifestyle and behavioral choices. So do you exercise? What nutrition do you have? What cognitive activities are you taking care of? Look, we're going to address these in much more detail later as we go through, but this is just an introduction. What cardio, metabolic factors you might have, social activities, what kind of social activities are you doing? Then we get into personality and individual thoughts. So what is your stress perception level? What are your personality traits? And then, of course, the genes are in the middle. So genes can strongly influence some of this cognitive reserve. Okay, again, so let's talk about this concept of cognitive reserve. Now we'll talk about what is that, how does cognitive reserve capacity contribute to basically keeping you from experiencing dementia or the effects of dementia above or not as severe as to those who would have had a lesser cognitive reserve capacity. And so there are both innate protective effects as well as the ability of the brain to actively compensate for this injury. Now, that some of the compensatory mechanisms can counteract symptoms until the ability to counteract that is overwhelmed. So in other words, the disease can be held off, the symptoms of the disease can be held off until we hit that threshold where you can no longer correct for it. And then we get this sort of massive decline here, like this blue line. So we're going along, we're holding off, and then it comes down quickly. Now, the red line is indicating someone who has a lower cognitive reserve. So the blue line here is a higher cognitive reserve. So you'll see that over this, fighting this Alzheimer's pathology, they can last longer over time than someone with a lower cognitive capacity or cognitive reserve. And then even the people with cognitive reserve, look, eventually they all end up with over the line of an incidence of dementia, but it takes longer, in fact, this much longer, for someone to experience dementia with a higher cognitive reserve than someone with a lower cognitive reserve. And brain plasticity, which is what we're talking about now, is thought to be a major factor in one of the major factors in the ability of the brain to fight this. So we got to also remember that this cognitive reserve includes both passive and active processes. So let's talk about what this means. So basically, passive reserve is accounted for by things like brain size and synaptic density, which are things like genetically and genetically determined or determined over life based on the activities that you've done. So, for instance, whether you've had a lot of mental stimulation, whether you've had an active lifestyle, whether you've had a lot of social stimulation, whether you've had cognitive remediation, and whether you've kept up physical activity throughout your life. Now, individuals with larger brains and greater synaptic density can tolerate more extensive pathology before they reach the threshold, obviously. And that becomes clinically evident when they hit that incident line that we talked about on the last slide. So active reserve refers to the efficiency with which an individual can use alternate networks or cognitive switching inside the brain to use different strategies to overcome the effects of the dementia. And again, that's all sort of to do with how your brain can use neuroplasticity to deal with these things. So what are some of the negative factors that can prevent to this cognitive reserve? Poor education, mood disturbances, poor nutrition, whether you have an alcohol abuse problem, poor health can also contribute to it. So there's a variety of things potentially outside of brain function that can contribute to the reserve that you are building or the reserve that you have built over your life. Now, let's talk about cognitive reserve versus brain reserve. Now, I know we might be, some people might think we're splitting hairs here, but cognitive reserve refers to basically metabolic activity that can be modified by mental activity. Brain reserve and cognitive reserve are not mutually exclusive. So mental activity is a strong signal for the generation of neurons and synapses. In fact, we know that people who, if you don't use the synaptic activations, they will eventually weaken or disappear. So use it or lose it is a definite rule inside the brain. So individuals that produce a lot of cognitive reserve can accumulate a lot of dementia-related pathology before they start to demonstrate symptoms. So again, we want to build this reserve as high as we can. Now, what are the things that build cognitive reserve as opposed to build brain reserve? Now, brain reserve is basically the brain's protective and compensatory ability in an overall functional capacity. So things like sleep, going into a sauna, eating berries, fasting, choline, walking, exercise, caffeine, curcumin, folic acid, meditation, resveratrol, calorie restriction, omega-3 fatty acids. These are all sort of things that are related to nutritional, lifestyle type things that you do throughout your life. They're going to build this brain reserve. Now, cognitive reserve is more looking at the synapses that we were talking about, connecting synapses and connecting neural networks and things inside the brain. So by doing activities like puzzles, writing, reading, doing different courses, even stuff like knitting, artistry, traveling to different places, different educational stuff, different socialization experiences, doing, handcrafts and eye-hand coordinative activities, what occupation you have, sometimes will relate to the cognitive reserve capacity, playing brain games, different social activities, meaningful and purposeful living, basically, also will contribute to that kind of stuff, to the building of the cognitive reserve in your brain. Now let's talk about plasticity for a minute. So obviously, there was a time where we thought that basically people were not able to change damage that had happened in their brain, and then brain damage was permanent, and there were no ways of reproducing neurons. There were no ways of reconnecting pathways once they had been damaged or not formed at all. Now we know that new neurons and synapses can form basically throughout life, even in old age. So this is good news for everybody. And this is very good news when we start looking at how can we use this neuroplasticity and the knowledge we have to help us avoid dementia. Okay, so let's talk about how long this plasticity remains. So basically, it's obviously more pronounced during early life, early development. However, it maintains its ability to change its structure. The brain maintains its ability to change its structure and function throughout life, in fact, well into old age. So if we look at neuroplasticity being this black line here, we see that it's big, high neuroplasticity, and then all through childhood, it's high, and then it starts to drop sort of into middle childhood. And then early adolescence, there's another rise. And then middle adolescence, it starts to taper off. But it does continue even into older age. Now, let's look at the contributions that different parts of your life have on this. So if you look at the parent and caregiver, you'll see that that keeps contributing to neuroplasticity all the way through childhood, even in through middle adolescence and late adolescence. We look at emotional regulation. It really starts to take effect sort of in the puberty ages, and then it continues on. So this is the hormonal component of neuroplasticity. And then we look at community. So as we are aging, community has a pretty reasonably significant contribution until puberty, and then after puberty, it actually rises into old age. And then our peers, we start to have our biggest peer contribution happens after puberty and then into sort of late adolescence and into older age. So you can see different things are contributing to neuroplasticity in at different phases in development and in different amounts during development. But all these things are important in developing that cognitive reserve, obviously. And then again, we have the teachers, which I didn't mention, but obviously they're going to surge in middle childhood, sort of middle childhood, early adolescence, when we're going through our sort of educational phases up until the end of high school, even in the end, a bit of college here. But then they start to taper off. They still have a significant impact even at the end. So teachers that you are involved with in your life, and it doesn't have to be teachers at a school, it can be teachers in life, it can be teachers in various other ways in which people will teach you things. You could have someone who you looked up to who taught you stuff and things like that. So they will have an effect on your life, mostly in the middle to early adolescence. That's just the way our society sort of has developed when we go to school. And we can argue about whether that's right or not at another time. Okay, cognitive plasticity refers to, in the literature, as learning potential changes in behavioral performance after training. So in other words, what this implies is that cognitive plasticity, we can change or we can improve through performance stuff. So that big list that I went through before, if we do those things, generally our cognitive plasticity will improve or it will build. And then we can, use that as a form of either treatment or a delay of dementia setting in. So one of the things that I thought was interesting was there are studies out there that show that listening to music can increase your risk for developing dementia later. So there's a good thing that now it doesn't, I don't know if it actually said what kind of music, but I would assume that complex music is probably best because it will have the biggest alterations in waveform. So your brain has to sort of figure those out. Okay, cognitive training. These are things that we can do So we're entering now into sort of how can we use neuroplasticity concepts to help people, to treat them for things that are happening to them where they may be in that mild cognitive impairment phase, or they don't want to get to that phase. So we want to help them do things that can change through using plasticity. So basically, cognitive training is one of the things that we use to illustrate plasticity, since it involves the structured practice of tasks targeting areas such as memory, reasoning, information processing, and improvements in memory, performance of individuals with dementia over time, with repeated practice, can be interpreted as evidence as that the cognitive plasticity is improving or is being affected in some way. So basically, the benefits of training cognitive plasticity are evident in everybody, even older individuals without dementia, although the improvements are more limited as we increase with age. Significant benefits can still happen basically throughout the rest of our lives. So if you have someone who you're worried about, a lot of them on a patient, or someone who you want to get doing things, let's look at how we can improve some of this plasticity through cognitive training. So obviously physical activity over the lifespan is important. So if they're not exercising, it's time to get them out, get them going. Combination of endurance, resistance, and motor coordinated exercise is the best if we can do that. So we want to have a mixture of things, not just one specific thing. Even stuff like dancing. Dancing is a very good way to improve cognitive performance because it involves a lot of things. It involves physical movement, it involves listening to music, it involves social interaction. So we get a lot of things happening with dancing. So we want to do things like reduce any risk factors that these people might be experiencing. So if obesity, systolic blood pressure, if they're smoking, try to get them to cut down or stop. Lifelong learning, so we could involve new things. Like I said, dancing is great. Or you can, if they don't know how to juggle, you can bring in some juggling. Or if they do know how to juggle, you can increase the amount of time that they're doing that. Social and cognitive activities, so traveling to different places, learning a new language. And traveling to a different place doesn't mean you have to spend a lot of money and go to a different country. It just means you have to go to a different place that you're not used to. So if you're used to going to a certain park, go to a different park. If you're used to going to a certain, cafe, go to a different cafe. Also, we have basically development of app-based learning, of course. So we can use the new advances in technology to help people through brain games, brain training games, those kind of things. Okay, so what are some rehabilitation strategies that we can use? So like I was saying, let's talk about treatment now, because really we can know all this other stuff about the theory of what happens in neuroplasticity, but in order to help people, we have to have actual things we can help them do to change what's going on. So if we look at, let's talk about increasing brain reserve. So this is basically one of the main things that often comes up is hearing loss. Hearing loss can really accelerate this whole cognitive decline in people. So you want to make sure that we preserve their hearing, we continue education, we can continue cognitive training, we continue with a rich social network, we try to reduce any kind of depression that might be happening. Exercise, obviously. Now, this is a Venn diagram, obviously, that is going to show us how all these things interact. So we're talking about increased cognitive reserve. We're talking about reduced brain inflammation. So basically adherence to exercise, which will decrease inflammation in most instances. Adherence to Mediterranean diet, and sometimes non-steroidal anti-inflammatories can help reduce that inflammation that's happening inside the body. So sometimes if people's inflammation can't be brought under control in any other way, we may have to use some pharmaceutical stuff. Now, we also want to look at reduced brain damage, and that is anything that we're doing that's going to increase the probability of either a vascular or neurotoxic or oxidative stress in the brain. So obviously, any kind of smoking that's happening, we want to stop or reduce. Treatment of things like diabetes, high hypertension, and high serum cholesterol are also necessary. And sometimes that will happen through exercise and diet. Sometimes you'll need some medical intervention there, so pharmaceutical intervention. Again, the lifestyle interventions are extremely important. So physical exercise, cognitive training, dietary modifications. Now, these will all lead to a positive influence on synaptic plasticity. So we'll look specifically here at exercise. So exercise, basically, if we increase creatine, L-arginine, and exercise together, we can get increases in all of these activities. So exercise will contribute to increases in a brain-derived neurotrophic factor, BDNF, and it promotes neurogenesis, which promotes neurogenesis, as well as vascular endothelial growth factor and cyclic AMP response element binding protein, or CREB. All of these things are positive in nature most of the time. So you want to try to get people doing exercise if they're not, cognitive training if they're not, and dietary modifications. Get rid of the smoke, get rid of the any air pollution if you can, that type of thing. So you really want to attack this from different multi-factorial areas. So we get from the combination of an increase in creatine, L-arginine, and exercise, we get increased neurogenesis, increased angiogenesis, we get increased synaptic plasticity happening, we get a reduction in oxidative stress, and we get increase in memory and cognitive flexibility. So these are all good things. So these are things that you want to look at. And from basically a dietary intervention component, we want to increase the omega-3 fatty acids, which will provide neuroprotective effects. Cognitive engagement. Now we're talking about building up these synaptic connections and promoting neuroplasticity by stimulating brain activity and delaying that cognitive decline. Now, a lot of this stuff is focused on the mitochondria, interestingly enough. So a lot of the things that affect mitochondrial function also affect the development of dementia. So we have things like inflammation, tau pathology, oxidative stress, accumulation of these amyloids, modifications of complexes 1, 3, and 4, age, genetics, and environmental factors all can contribute to this mitochondrial decline. And we want to, so basically what happens when that mitochondria starts to not work right, we start getting an increase in reactive oxygen species generation, which can result in liquid peroxidation and DNA damage. That leads to apoptosis of the cell, which means that the cell will die. We get increase or decrease in ATP production. That means that we get a reduction in cellular function, obviously, because we don't have enough ATP. And then we get this reduction now in MPTF and MPTP activation, which leads in a increase in apoptosis here, which means the cell will die. Now over here, we get increases in things called fusion and fission. Fusion and fission is the weird thing that happens to a mitochondria, where it starts to break up into pieces, and then the cell will digest those pieces and then reproduce a new mitochondria. So that is called autophagy, and that will start to decrease. So we get a decrease in the reproduction of new mitochondria in these cases. So the beautiful thing about these things is that when we're talking about patients and we're talking about brains and things like that, these interventions can be customized specifically for the person. And we can get improved quality of life for the people, and we can also get a reduction in either the rate of decline or the speed of decline or the actual level of decline that these people are going to experience. Now, what other things can we do to help people that either are in this rapid decline or have started to develop dementia proper? Well, obviously, healthy eating and exercise, which we've discussed and talked about, stuff like cholesterol metabolism, vascular mechanisms, reduced inflammatory activity, all of these things need to be addressed. Now, we've also got some modalities that we could use to affect function in the brain. And most of these modalities will, so for instance, we have TMS, transmagnetic stimulation, and transdirect current stimulation. Now, the transdirect current stimulation and the transmagnetic stimulation work on the same areas of the brain, and that those are the synapses, but they do it in different ways. So the magnetic stimulation will actually produce an action potential reaction in most cases, whereas this TDCS only affects the synaptic generation potentials. It doesn't actually produce it doesn't actually produce action potentials. And then we also have laser, transcranial laser, which is starting to become a lot more research is being done on that. And that transcranial laser activation does affect the mitochondria mostly. So it'll affect mitochondria production of ATP. It'll also affect the production of ROS. Would also affect production of neurotropins. Okay, so I hope that this little presentation has helped you understand things like cognitive reserve and how to increase that cognitive reserve and that brain reserve to help people avoid dementia, avoid the effects that is going to have, either the natural effects of aging or the effects that they have brought on themselves through lifestyle and through, that no fault of their own, through their genetic makeup. Okay, we'll see you next year at the Neurology Summit again. And please send me an email, rbeck@ifn.net.au. If you have any comments or if you have any questions, let me know, and I'll try to get back to you. See you later.
Well, thank you for your excellent presentation. I'm going to go through a summary and a couple of questions for you. So we
Yep, no
started by
problem.
talking about normal brain aging, and we were looking at subtle cognitive changes. And so age-related changes include ventricular enlargement, cortical thinning, decreasing gray and white matter associated with volume loss, and then sulcal widening. Dementia is part of a continuum of brain aging. So the prodromal stage of dementia is similar to brain aging symptoms, but dementia is a syndrome of gradual and progressive cognitive decline due to a variety of underlying pathology, Alzheimer's being the most common form of dementia. And then we're really looking at that continuum. We also talked about mild cognitive impairment. So with mild cognitive impairment, it's a prodromal stage of dementia. So decline is evident more so than normal cognitive aging. And memory impairment doesn't affect ADLs yet, but if mild cognitive impairment continues, it can take a rapid decline to dementia. And then this is going to interfere with activities of daily living and independence. So mild cognitive impairment diagnosis has subtypes. We have memory problems associated with challenges to take care of like monthly bills, impaired thinking skills, so misplacing things often and can't find them, language difficulties, you have trouble making a conversation, disorientation, time and space, so fully losing track of the day and time and it doesn't come back, and then poor judgment, so making poor decisions a lot of the time. With cognitive reserve, it's a progression of dementia symptoms vary considerably with the same underlying pathology, but if we have cognitive reserve, which is the ability of the brain to withstand certain level of injury before the clinical manifestation of dementia. So larger cognitive reserve can go longer than somebody who has less cognitive reserve, even if they have the same amount of pathology within the brain. So build cognitive reserve through things like environment, lifestyle and behavioral choices, personality and thoughts, our stress perception level, as well as genes. And then cognitive reserve capacity. So we can hold off the disease until threshold. So this leads to significant decline. And then the plasticity of the brain is thought to be a factor that contributes significantly to the ability to build cognitive reserve. Reserve includes passive and active processes. So, passive, the brain size and synaptic density, and active would be the efficiency of cognitive switching within the brain to overcome the effects of dementia. And the negative neuroplasticity for cognitive reserves is mood disturbances, alcohol abuse, poor education, poor diet, poor health. And then, if we look at cognitive versus brain reserves, so with cognitive, it's a metabolic activity that can be modified by mental activity. So, habits for neuroplasticity for cognitive reserve are things like puzzles and writing and reading and courses, knitting, artistry, education, traveling, occupation, socializing, doing brain games, and having that meaning and purpose to life. Whereas brain reserve is going to be associated with things like sleep and sauna, eating berries, fasting, choline, walking, exercise, caffeine, curcumin, meditation, as well as omega 3s. So, with plasticity, new neurons and synapses are generated throughout life. Pathways remodel in response to changes in the internal and external environment. Brain plasticity remains throughout life, so more pronounced in early life, but we can continue to change the brain through into old age. And with cognitive plasticity, we can change and improve through performance, which can be a treatment for the delay of dementia. And then cognitive training illustrates plasticity, so memory and reasoning, information processing, lifelong learning of new movements, social and cognitive active lifestyle, physical activity, reduced depression, reduced inflammation, and obesity. And then rehab strategies to leverage neuroplasticity, so targeted therapies that aim to enhance recovery by promoting beneficial plastic changes and minimizing the maladaptive ones. With lifestyle interventions, also consider creatine, L-arginine, and exercise because together they increase neurogenesis, angiogenesis, synaptic plasticity, and memory. And then cognitive engagement, so looking at our mitochondrial function. If we have things like inflammation and tau pathology, oxidative stress, and age, they all impact mitochondrial decline. So decreased mitochondrial function can lead to cell death and reduction in cellular function due to decreased ATP. Non-invasive brain stimulation to help improve mitochondrial function include transcranial direct current stimulation, transmagnetic stimulation, as well as transcranial laser. Really excellent presentation. Thank you again so much. A couple of questions for you. When
Absolutely.
Wonderful. So, when you are having patients exercise from a perspective of building cognitive reserve, what do you recommend? So, they're physically doing exercise. What do you recommend that they think about? Do you want to dual task them to keep them highly cognitive active, or do you want them more focused on their body and how they feel somatically, or do you like to let their mind wander a little bit to be creative? What do you think is the best to target their brain cognitively while doing physical exercise?
Well, that is an amazing question. So thank you for that one. I think the truly most effective way is to mix all that up. So have a mixture of all those things. And that's why doing things, first of all, you have to do things that are sustainable. You have to do things that people like to do.
Mhm,
So if you have something like dancing, that's perfect.
mhm,
Okay. If you enjoy dancing and you like going out and dancing and, going out to and meeting new people, dancing, or even with the same partner, it doesn't matter. The point is you're out, you're moving, you're taking part in a social situation, you're listening to different music. So it's a very complex activity actually. And I suppose that the main thing is that you want to do it on a consistent basis. And it's the consistency, I think, that matters
mhm.
the most. And
Absolutely.
so, if let's say you're going to the gym 3 times a week, that's great. But if you're going 5 times a week, that's even better,
Mhm.
especially if you're enjoying it. Like you're going because you want to go.
Right.
And when you get there, you do stuff. You're not just sort of, standing by the equipment talking to someone.
Mhm.
You're actually doing stuff. Yeah. So I think a mixture of all those things is the best.
Excellent. And you talked about transcranial photobiomodulation or laser
Mm.
activation. Are there specific areas that you're pointing the laser at on the brain specifically for mild cognitive impairment to then prevent, to build cognitive reserve and prevent it from going into dementia?
Well, that is another excellent question because what you really have to do for the laser to be effective is you have to know what areas are being affected, I suppose. And one of the ways to do that is do an EEG.
Mhm.
So you do an EEG, you do a brain map, and then you know with relative, certainty what areas are having either decline or they're not connecting properly with other areas, and then you can apply the laser to those areas.
Excellent. Wonderful. Thank you so much. And as we wrap up another great session today on the Virtual Neurology Summit, I'd like to acknowledge Dr. Beck for his excellent work in functional neurology. And to all of our viewers, I'd like to acknowledge you. Thank you for your commitment to brain-based correction and objective clinical results. I'm Dr. Krista, your host of the Virtual Neurology Summit. Be sure to check out the Postural Neurology program to get certified in brain-based postural correction. Stay tuned, and we'll see you on the next Neuro Masterclass of the Virtual Neurology Summit.